The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Thanks for joining us today for our You Are the Key to HPV Cancer Prevention webinar. My name is Carmen Boone, Education Coordinator from Oregon Pacific Area Health Education Center, a hosted agency of Samaritan Lebanon Community Hospital. Today, I will be your host and moderator. Let's go over some housekeeping items. On your GoToWebinar control panel, you will notice that all microphones are muted, and they'll remain muted during this session. If you are experiencing audio difficulties, make sure your computer speaker volume is turned up or use the phone option to listen in. Slides can be downloaded from the handouts option. Also, we will email them to you by request, so you can email me and ask for them if you'd like them. Please use the questions options for typing questions or comments at any time, and questions will be answered at the end. If we run out of time, we would still answer your questions via email and email you the Q&A by the end of the week. This webinar is being recorded and will be available on our website at the email address the web address that you see up there. If you have any questions, please email me at carmenb@samhealth.org. It's the same email that you will find on your GoToWebinar confirmation emails. To obtain CME or CE credit for this activity, you must log into www.eeds.com and enter this activity code 47KEEK. Please write down the code for your records and email me if you have any trouble. This presentation is jointly provided by the National AHEC Organization and the American Cancer Society, Samaritan Health Services, and the Oregon Pacific Area Health Education Center. Thank you to Char Runyo and Dr. William Rueg for allowing us to bring this presentation to you today. Dr. Buser and the planner of this activity report that we don't have no conflict of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. Dr. Rueg wanted to introduce Dr. Geneviere Buser, but I think, oh, there you are, Dr. Rueg. Yeah. There. So I'll leave you with Dr. William Rueg, who will introduce our speaker.
Thank you, Carmen, so much. This is Daniel. This presentation is part of an HPV vaccination project that Dr. Buser is going to tell us about that is in collaboration with the American Cancer Society. Dr. Buser has been working with them on HPV vaccination rates and HPV cancer prevention. But additionally, she's actually our pediatric infectious disease doctor. So most of us have had the pleasure of working with her when we have had tricky newborn or pediatric infectious disease we work with. She's also been part of the Women and Children's CQI work around vaccination projects, which they have done impressively. So Dr. Buser has been with Providence for a number of years now and has the long resume of somebody that is befitting to somebody that is a pediatric ID specialist. But I think most importantly, she works really closely with us and with the Women and Children's CQI to improve these preventative care metrics. So Dr. Buser, thank you so much for being with us.
Thank you so much for that introduction. I really appreciate that. Yeah, so I was talking with Char and Carmen that we've been working on this HPV awareness and vaccination for several years now, and I'm excited to keep it continuing. And of course, there's statewide also HPV efforts that go on. So this is really exciting to be a part of this. So today I'd like to share with you about human papillomavirus infection and disease, then about the vaccine and why it's important for cancer prevention. I will talk about the HPV vaccination schedule and describe its effectiveness, as well as the data around safety and efficacy. And finally, I'll end with a section I find very interesting is about how to facilitate conversation and uptake of vaccination with your patients, or more correctly, their parents. So let's dig into human papillomavirus infection, which is really very a fascinating family of viruses here. There are many different types, over 150 types, that infect both mucosal sites of infection or cutaneous sites of infection. The cutaneous ones are your common hand and foot warts, so we won't be talking about those. We'll be focusing on those that infect mucosal sites of infection, and specifically those that are in this high risk category here. And let's see if I can, I don't know if you can see my pointer here, but specifically here, HPV 16 and 18, which are the most common high risk oncogenic, meaning cancer promoting types of this virus, associated with cervical cancer, anogenital cancers, oropharyngeal cancer, and other cancer precursors. There are also other types that affect mucosal sites. HPV 6 and 11 are the most common. Those cause lots of other disease like genital warts and laryngeal papillomas, but aren't associated with the potential for cancer, but do represent a significant morbidity, and I'll talk more about that. So human papillomavirus infection, it does have human in the name, and so accordingly, most females and males will be infected at some point in their life with at least one type of this mucosal HPV. And so currently, the prevalence is estimated at 79 million Americans are currently infected in the mucosal surface with one of the HPV types. 14 million new infections likely occur each year in the U.S., not to mention worldwide. And we usually acquire this virus at the onset of sexual debut, so usually in their teens and early 20s. And hence, that'll be important when I talk about vaccination timing. Importantly, most people will never know that they have been infected. They won't have any signs or symptoms, perhaps until they have cervical dysplasia or oropharyngeal dysplasia or even cancer. I'd like to review here the timeline of HPV infection because it's important to understanding where vaccination fits into this. So if we begin on the left here, and this is focused on the cervix, and so it may not apply to every other site, but generally for the cervix. So here one has a normal cervix, and then with sexual debut we have exposure to the virus, and you have an HPV infected cervix. And actually most women will end up clearing that transient infection, and it will not go on to disease. However, over the next 5, 10, 15, 20 years, a certain percentage of women will have changes in their cervical cells with precancer, and hence this is where the pap smear is so important in order to identify those early precancerous changes and do early interventions. But even despite that, some women will then later on go on to develop cancer. But again, we're looking at decades of that this disease or infection, can become disease over decades. And that's where this importance of the vaccine to vaccinate prior to any exposure is so key. I want to begin, before talking about the cancer, I actually want to talk about the precancer, because this is actually responsible for 196,000 high-grade cervical lesions every year in the U.S. are diagnosed in women. That is an incredible amount of colposcopies, LEEP procedures, cone biopsies, etc. That should not be underestimated. In Oregon, the rate is about 350 cases of high-grade cervical lesions per 100,000 women every year. This is very significant. And then when you get to cancers, the numbers are less, but obviously very important as far as the morbidity and mortality. This table summarizes the cancers that were reviewed in the years between 2012 to 2016 in the United States. And overall, there were 34,800 HPV-associated and attributable cancers. I want to just pause here a moment and talk about associated versus attributable. Associated means that this is a cancer that's occurring, as you can see in this left cancer site, in this column here, cervix, vagina, vulva, penis. These are all sites that we do know that HPV causes cancers. So we call those HPV-associated cancers. When extra testing has been done and they've actually looked to see if they can find DNA from the human papillomavirus, that's where this third column, where it says percentage probably caused by HPV type, this is your attributable, where they've actually found HPV cancers. As you can see, it's a vast majority, so often these terms are interchangeable, but there is a small difference. So for instance, with cervical cancer, 91% of those are probably caused by human papillomavirus. With oral pharyngeal, probably about 70% are. So just some important things to keep in mind going forward. This is another way of looking at HPV-associated attributable cancers per year in the US for the same time period, 2012 to 2016. And you can see here for cervix, those caused by human papillomaviruses 16 and 18 caused the vast majority here, 8,000 out of the about 12,000 or so that were reported. And down here in oropharyngeal cancer as well, 16 and 18 caused the vast majority of those. And there's some additional cases that were by these other what we call high risk or high risk human papillomavirus types here in the teal blue, 31, 33, 45, 52, and 58. And this is important. We'll talk more about this when it comes to the vaccine. Our original vaccines were against 16 and 18 primarily, and now the most recent 9-valent includes these extra 31 through 58. So we're getting not every single type that's associated with cancer, but upwards of 80 to 90%, which is really exciting. So let's dive a little bit more into the epidemiology. So here is, this slide here is showing the cancer rates by sex, race, and ethnicity in the United States from 2012 to 2016. And overall, women are in the solid bars and men are in the hatched bars for the different colors. Overall, about 13.7 per 100,000 women had some kind of HPV-associated cancer, and for men it was 10 per 100,000. So these are common cancers, most commonly seen in white and black, and overall fairly split between Hispanic and non-Hispanic, but we'll see how that changes a little bit when we get to the different cancer types. This is a slide showing HPV-associated anal rectal cancer, which also includes anal and rectal squamous cell carcinomas, which usually we're talking about mucosal versus squamous cells, a little bit different, but it is related to HPV. This tends to be more common in white females and non-Hispanic. Excuse me, this is my little thing here, non-Hispanic. For oropharyngeal cancers, this is the most common HPV-associated cancer for men, affecting about 15,000 men per year in this time frame, and more common amongst white and black males and non-Hispanic males. Again, causing significant morbidity, more difficult to treat than cervical cancer. HPV penile cancer, this is about 1,300 males per year diagnosed with this, not as common and more common amongst Hispanic males. Vaginal cancer rates among women, when you break it down by this, more common for Black and Hispanic women, and we'll see this trend again with cervical cancer, and I'll talk a little bit more about that later. Vulvar cancer, this affects about 4,000 women per year in this group, more common in white and non-Hispanic women than other races. And finally, cervical cancer, which is going to be the most common HPV-associated cancer for women, affecting overall 7.2 per 100,000 women in the United States. More common, as you can see, amongst Black and Hispanic women. And the concern there is that this might be because of decreased access to appropriate screening and follow-up treatment, i.e. pap smears, colposcopies, etc. Because this isn't just the high-grade dysplasia. This is actually the cervical cancer. So something to be aware of, and there's also a lot of efforts going around to improve screening. Overall, about 12,000 women per year are affected by cervical cancer. And as I mentioned that before, and I think understanding the burden in the United States is important, but also worldwide, I think is pretty staggering. That they estimate more than 569,000 new cases and over 300,000 deaths worldwide in 2018 due to cervical cancer. Probably many of these are preventable, by pap smears and early interventions, but that's just not possible in the whole world. And we think we can do better, not only for the women in the U.S., but around the world. And I think importantly for the epidemiology as well is that half of the cervical cancers occur in women who are less than age 50 years, and a quarter of cervical cancers amongst women 25 to 39 years old. And this is important because this is our prime childbearing years, and treatment for both the high-grade dysplasia and cancer can lead to infertility because of either affecting the cervix, causing, or other having to do total removal. So really, really important disease here for our young women. So we think, as I said, we think we can do much better, and that's where I come to talk about the vaccine. And really, I think this slide, and there's another slide, I think really that HPV vaccine is cancer prevention is super important to be able to communicate. It's one of two vaccines, hepatitis B actually being the other one, that can prevent cancer because we prevent the primary infection. So HPV, the prophylactic vaccines are all based upon this recombinant L1 capsid protein that forms a virus-like particle, and it's actually pretty cool when it actually folds into shape automatically when it's manufactured by the cells. And so the body looks and sees the surface of what looks like human papillomavirus, but it is not infectious and it is not oncogenic. And so it produces a very robust and specific antibody response, actually producing higher levels of neutralizing antibody than natural infection would. So it's very interesting, just technology behind this. So what vaccines are out there? Overall, there's the bivalent, quadrivalent, and 9-valent vaccine. In the US currently, there's just the 9-valent. But I do want to just at least talk about the other ones because they're very important. The bivalent, quadrivalent were original ones, and they both contain the 16 and 18, which, as I showed on the earlier slides, represents probably 60 to 80% of the HPV-associated cancers overall. They say 63% here. The quadrivalent and 9-valent have the additional 6 and 11, which are the main causes for genital warts, and so it has some added benefit for non-cancer disease. What the 9-valent added, when I added these remaining 31 to 58 types, is that it increased, it says 10%, but like 10 to 15% of cancers in the body, it covered an additional part of those. But really, the vast majority were affected by 16 and 18 by even our earlier vaccines. And so you'll find these, the bivalent and quadrivalent are licensed, and so they might be elsewhere in the world, but the one we're using right now is 9-valent, but the other ones are very good. So what age should we be vaccinating our young people? As I mentioned on that slide with the timeline of disease, we want to vaccinate prior to exposure, so that's where the recommended age is with the adolescent visit at age 11 or 12 years old. It's actually licensed down to age 9, and safety and great immune response as well. But we're focusing on it with the other adolescent vaccines. Anyone who's missed in the adolescent years, they recommend catch-up vaccination for everyone through 26 years if you haven't been adequately or previously vaccinated. It's not widely recommended for everyone older than 26. However, it is encouraged for people age 27 to 45 to have a conversation with their clinician to see if they have risk factors, if they weren't vaccinated, if they have new risk factors, and that they might be able to have some benefit. We hypothesize there's probably less benefit because if they have been sexually active up to that time, they've probably been exposed already, but again, it kind of depends on a case by case. So older than 27, we recommend conversations with clinicians. However, for the teens, the dosing schedule, if you start before your 15th birthday, we recommend at age 11 to 12. It's a 2-dose schedule, And the second dose will follow the first dose by 6 to 12 months with a minimum interval of 5 months. And that's really important because this is a prime boost kind of approach that they're using here. And with the younger kids, we can get away with a prime and a boost, and they have a good enough immune response that that is sufficient. However, when you start on or after the 15th birthday, you have to have a third dose in there, prime boost. So at time 0, time 1 to 2 months, and then 6 months in order to get the similar immune response. So again, one of another reason why we want to recommend starting at that age 11 and 12 time period. I do want to note that if you're vaccinating anyone who is immunocompromised for the reasons usually given in the Red Book for that, then it is recommended they get the 3-dose of HPV vaccine, a prime boost. The administration is like other adolescent vaccines. It'll be to the deltoid muscle, the upper arm by IM injection, and always important to use aseptic technique. And I would say for adolescents, we want to do some monitoring post-vaccination as they tend to be more prone to having syncopal or pre-syncopal episodes with vaccination. Let's talk a little bit about HPV vaccine safety. This is always a big topic. First of all, I want to step back and say the United States has a robust multi-layer vaccine safety system in place, and not just for HPV vaccine, but for all vaccines, including the new coronavirus vaccines that are under development. And it involves multiple layers, both with the CDC, FDA, healthcare systems that provide, and academic centers that provide large databases, and other partner organizations that include these huge populations. You can see even this last one, the Post-Licensure Rapid Immunization Safety Monitoring Program, or PRISM. It uses a large database that covers about half of the US population, so really able to find some rare and serious side effects if there were to be any. And these are in place for all vaccines. So what we know after more than 10 years, 12 years or more, the first HPV vaccine was licensed. They were licensed in 2006, so we're actually 14 years. With this data, both the United States and around the world, we know that HPV vaccines are safe. Common reactions after vaccinations may include things like pain, redness, swelling of the arm where the shot was given, and systemic fevers and headaches. But the systemic ones are much more rare. Usually it's, the injection site reactions. Again, some pre-syncopal and syncopal episodes can be seen with teens, so you want to do some monitoring of that. As with any, bullet point 3, as with any vaccine, you don't want to give it to anyone who's had a previous allergic reaction to the HPV vaccine, or who has a severe allergy to yeast, as that there might be some small amounts remaining in the vaccine. This is specifically for the 9-valent HPV vaccine. They want us to give you some details of what sort of monitoring is going on for that. So VAERS report, which is the Vaccine Adverse Event Report, which as a provider, you may have reported something into this in the past, but it really is just to be a catch-all for anyone who has a concern. But people, so there's that reporting. They data mine it to find if there's actually any significance to any of those reports. There's a vaccine safety data link, which is near real-time monitoring of some pre-specified outcomes that we're concerned about. For example, spontaneous abortion is one of them. PRISM, as I mentioned, is that enormous database that can monitor for very rare and serious unexpected events in a significant portion of the United States population. And then there's also manufacturing post-marketing commitments where they have to do their own monitoring and studies to assess for long-term safety. And this includes a pregnancy registry. And just, this will also be what's going to be going on for the coronavirus vaccine, just FYI. Some other population studies worldwide. It's been studied in more than 100 million doses. And specifically, there was a well-done study out of Denmark and Sweden who have a national healthcare system and an electronic medical record system, so they're able to really track people and outcomes very well. They looked at, followed nearly 300,000 girls and over 700,000 doses. and they had some predefined signal strengths that none of these outcomes of autoimmune disease, things like that, they didn't actually meet any of those signal strengths, and they also didn't have biological plausibility. They had, the timing was wrong and things like that. So they did this really large population study that did not show that there was association with these outcomes of concern. There, as you can imagine, there are case reports in small series. As with any vaccine, you can have potentially these small case reports, but they have not borne out in larger studies as being widespread complications. But it's important to continue to monitor those, and it is being done. So overall, we know that the HPV vaccine is safe, and so that should be very reassuring, and also that there's ongoing monitoring along the way in case something new does arise. And so there's, feel that we can reassure parents that have any concerns that the HPV vaccination is safe and will provide lots of benefit to their children. And that will be the next section I will speak to. If you have any ongoing concerns about safety, effectiveness, or what the data is more specifically, they have a great website here at the CDC vaccine safety data that looks at even the different vaccines, Gardasil, Cervarix, et cetera, and compiles the trials that were done and what their outcomes were. So that can be also helpful to you and for some parents who are interested in more detailed data. So let's talk about the vaccine effect. And of note, because HPV is both infection, and then we have these early pre-cancers, and then we have cancer, we want to look at how does it affect all of those outcomes, both early, mid, and late. Understandably, we have most data around early and mid outcomes, but actually, excitingly, we have some new data on late outcomes that I'll share with you. So here we go. So along with looking for safety, we've also been, the research community has also been monitoring for the effectiveness of the vaccine in changing these early and mid outcomes. And what we know from population levels in many countries, especially, which is great in countries that have excellent electronic medical records where they can follow this very closely, that there has been improvements in HPV prevalence among the HPV types that are included in the vaccine. They've seen declines in genital warts, which, although not cancer, it causes significant morbidity, and they've seen decreases in cervical lesions, i.e. precancerous lesions. And the smattering of countries that's included here are important because, for instance, Australia, they had mandatory vaccination for teenage girls into their school system, so they had very high compliance, as did some of these other Northern European countries. So really we're able to study these effects very well. There's also been studies on the effect in the United States, and we've also seen declines in vaccine type prevalence, genital warts, and cervical precancers, and I'm going to share a little bit of that data with you. So this slide here looks at vaccine type prevalence among females through the NHANES, which is a large national sampled survey across the United States of men and women. And they looked, and they also do, in addition to asking a whole bunch of questions, they also will take bloods and urines and do some other biological testing. So it's pretty exciting. It reveals some interesting data. So what they looked here is they looked at women in the pre-vaccine era from 2003 to 2006. Again, the first vaccines for type 16 and 18 were licensed in 2006. Then they looked at the early vaccine era from 2007 to 2010, and then a later vaccine era, from 2013 to 2016. And so you imagine these women are going forward through the study as cohorts, if you will. And what they saw in the younger groups, so the 14 to 19 years and the 20 to 24 years, who would have been a part of that early vaccine and later vaccine era, that there is a significant decline in the vaccine prevalence types. So if you look at 20 to 24 years, there's a 71% decrease in the circulating vaccine types that they're finding when they investigate women who have HPV disease, and an 86% decrease. very significant. The older types a little bit more, but they wouldn't have been probably vaccinated, but we'll talk a little bit more about herd immunity later on. But some very exciting suggestive data that the vaccine is affecting the types of circulating or decreasing the circulating oncogenic types of virus. Also, this is a slide on vaccine type prevalence amongst minorities, 14 to 19 years old, which has also been affected. You can see here in non-Hispanic Black women, there was a significant decline of 74% in vaccine types causing disease, and in Mexican American, 87%. So this is really nice to have some of this additional data on minority females as well. So that's just the vaccine type. So let's move on to actually precancer. So a little bit further down the pathogenesis of HPV. This is an interesting study that actually Oregon contributed data for. It's a cervical precancer incidence rates among screened women, the HPV Impact project from 2008 to 2015. And this is where they collected, de-identified pathological samples for carcinoma in situ, and they did HPV testing on it to look to see what was there. But they also just looked at the precancer rates as well. And so, and it's I think 5 sites, if I'm not mistaken, around the United States that contributed data, Oregon being one of them. And over time, you can see that of the women who underwent cervical screening, actually finding precancer began to decline about 2012, 2013. So it's about 6 years, post licensure for the vaccine. And you can see some also in the 18 to 20-year-olds as well. There we go. So that's exciting. I think kind of middle. There we go. Excuse me. Got my slides. Middle term for showing that we have some decline in those precancer rates following introduction of the vaccine. There's also some interesting data in males, actually, secondary protection in Australia. So this is looking, so as I mentioned before, Australia were vaccinating their female youth, but not their males. But they followed and studied what was the incidence of genital warts in both populations. The females are shown on the left, males are shown on the right. And you can see the vaccine project started about 2007 there with the vertical dotted line. And you can see where the incident or percentage, I should say percentage of having genital warts at first visit significantly declined amongst females. And there was also a slower, more delayed, but significant decline in males. And so the suggestion here is that even with vaccinating females, you're decreasing the transmission and dissemination of those disease-causing types in the population, which is very exciting. Rolette et al. Did a lovely systematic review and meta-analysis at population level that showed the impact of HPV vaccination, and they in 14 different high-income countries. And what they found globally through this is that at about 5 to 8 years of vaccination, that among 13 to 19-year-old girls, they saw a decline in the HPV 16-18 prevalence, which again are those oncogenic types, by 83%. And this correlates nicely with the Oregon or the HPV Impact, where Oregon contributed data, where it was about 6 to 8 years after where you started seeing that decline in precancer lesions in women. So that also, parallels that well. And they're also seeing declines in genital warts. And as again noted, amongst the 20 to 24-year-old, they saw the decrease in cervical precancers. So really data from all over the world and the United States showing this fairly rapid effect. I mean, I think 5 to 8 years is pretty rapid vaccination, decreasing some of these early and mid outcomes of HPV disease. As I mentioned, also other countries as well saw some of this herd effects where boys and men who weren't vaccinated seemed to benefit from not seeing as much of the disease-causing HPV strains. This study that just came out is really the pièce de résistance. You can see a little yellow star here. This is really one of the first studies, and unfortunately it was a little bit overshadowed by COVID because it came out in the New England Journal of Medicine this year. But Sweden has, in a study that was done in their healthcare system, showed a protective effect of HPV vaccination against cervical cancer. So this is really one of the first, if not the first study to give some great data on how the vaccine can prevent late outcomes of cervical cancer due to human papillomavirus. So very exciting stuff. So again, this is a population study done in Sweden. They followed over 1.6 million women aged 10 to 30 years old, and they followed them forward over time until either they reached age 31 at the end of the study, or they developed cervical cancer. And the time frame was 2006 to 2017. And what they found is if they were vaccinated, they had, well, the technical is an adjusted incidence rate ratio of 0.37, but translated, that means that vaccinated women had 63% less incidence of cervical cancer than unvaccinated women, which was very significant in their study. You can see their 95% confidence intervals were 0.21 to 0.57. So this meaning that the incidence of women, getting to the endpoint of cervical cancer was decreased, was 63% less. What was even more interesting was that if they were vaccinated before age 17, there was an 88% less incidence of cervical cancer developing during the observation period. So once again, really emphasizing the importance of vaccinating prior to exposure in the early teen years. It seems to have the most benefit for the later outcomes of HPV-associated cancer, and likely precancers and other disease like genital warts, et cetera, because you're vaccinating prior to exposure. So very neat stuff here by Lei et al. We also have data around HPV duration of protection, studies that have shown that it probably is long-lasting and does not seem to have any waning immunity, at least by the testing that they can do in studies for at least 10 years, but this will be borne out over time. So in summary, takeaways is that HPV vaccine is safe, and the benefits far outweigh any potential risks that can happen, which are usually, again, just like the local injection site, maybe some pre-syncope that can happen, and that they are the safety monitoring mechanisms in place that are similar for all their vaccines continue to show that HPV vaccination is safe. Secondly, the HPV vaccine works. I hope I've showed you some data that we are seeing declines in both early, mid, and late outcomes, which is very exciting. We should probably update this slide here now that we have some new stuff, and that vaccine protection lasts. So that's kind of more like the background, the nitty-gritty, the epi, and the disease and vaccine. So, now that you're convinced, or maybe you didn't need to be convinced, but some good background data, how do we talk to this, to our patients and our parents? How do we frame the conversation? And really, should it be any different than any of our other vaccine conversations? Just to give you a sense of how HPV vaccination does as compared to other adolescent vaccinations, this slide shows adolescent vaccination coverage in the United States from 2006 to 2018. And I just want to point out, I think it's quite surprising that back in 2006, obviously adolescent vaccination was not on the radar. But and you guys have done amazing improvements over that, especially when you look at the Tdap and meningococcal. Those are the red and the blue lines. The HPV over here is going to be in yellow and green and orange. And so where one is one HPV vaccine and three or more is HPV is in yellow, and up to date is green. So the reason it changed to green is that we went to the 2-dose schedule, and so there's differing definitions. So if you want to follow just the green one's up to date. So you can see we've made some progress from about 40 to maybe almost 50% in the last 4 or 5 years. And we're definitely doing better on our initiation of the series, but a gap between our initiation and completion of the HPV series. Here is a state statogram, if you will, for HPV completion rates in Oregon from 2019 amongst teens aged 13 to 17 years old. And this is looking at whether you define it as 2 or 3 doses, depending on when they started. And you can see that there's a wide variety of completion rates in the state, ranging from about 22% in Grant County to 60% in Multnomah County, which is still only 60%. It's not our 80% that is the goal, that I believe is the goal for American Cancer Society, but also for CDC. We're trying to reach that higher goal of 80%. So we still have a ways to go, and there's a lot of variability, both between more rural and more urban counties. So when they've looked at why are we doing actually quite well with Tdap and meninge, but not so well with HPV, a lot of that has to do when they looked at the studies, and this is a survey that's done by CDC that hasn't been published, but NIS Teen from 2015 to 2018. And what they found is that there's probably, most because of a lot of missed opportunities. So this graph and the red bars show you that's the amount of kids that were vaccinated on this visit for the Tdap and the meninge, and the HPV, and then the blue bar is who were vaccinated for HPV. So there were a lot more kids in there who got their Tdap and the meninge appropriately, but they did not get their HPV at the same time. And it's pretty similar between boys and girls, where we could probably have gotten to 95% coverage if all of those who had received the Tdap and the meninge had also received the HPV. So this is a big focus on this program, is closing that gap between missed opportunities. This is a shout out to the rural areas. They tend to consistently have lower vaccination coverage over time. It has improved, but still seems to have that gap. And so this can be, some projects in Oregon are specifically focusing on rural areas as well and improving that gap there. So as part of this NIS Teen survey they did in 2018, CDC asked parents, what was the reason why you didn't start the HPV vaccine series? And while safety and side effects concerns were one of the most common, about 25%, 10% said that it wasn't clearly recommended by the provider when they were there for the visit. So that's something where we can have an action there. Some of the stuff we can probably affect their lack of knowledge. We can try to address some of the safety concerns as well, try to convince them of the importance of the HPV vaccine, but we should also definitely be recommending it at the appropriate visits. This is from Dr. Heatley et al. They asked parents what value they placed on vaccines, and from the parents' point of view, they actually value all of these vaccines fairly equivocally. However, when you asked physicians what they thought parents, or what value they thought parents placed in the vaccines, you see something different here. Clinicians agree that parents think meningitis, hepatitis, pertussis are important, but they didn't think that parents thought that influenza and HPV were that important, which is contrary to what the parents were saying. They thought that those were also important. And so there is this difference of perception, which might, be kind of an invisible barrier of how we speak to our parents, and we make some assumptions on them. This is and that giving that clear recommendation is actually very important and can affect the parent's decision. So as part of that NIS Teen survey in 2018, they asked if the parents had received a recommendation. Amongst those who said yes, 75% went on to agree to have their children vaccinated for HPV. However, those who did not receive a clear recommendation from the provider, 47% still went on to get vaccinated, but that was a big difference versus 75% who did when they were given a clear recommendation from the provider. So the CDC really wants you to think about these perceived and real concerns of parents, how they influence how clinicians recommend HPV vaccine. And so there may be some perception that parents are hesitant or don't think it's important, but what's more effective is to really understand what is this individual parent's concern if they really don't want it, and addressing that rather than just assuming, and that it is important to give a clear recommendation. And that likely the best age to do that is for that age 11 or 12 adolescent visit when we're doing meninge and Tdap at the same time, and giving an effective recommendation from their trusted provider. And this has come out also in focus groups that, while parents may seem to be reticent or push back, they may just be really having honest questions of clarification, but that they do appreciate a clear recommendation from their trusted provider. So what is an effective recommendation for HPV vaccination, or any other vaccine for that matter? But for HPV, we talk about doing it the same way, same day as other adolescent vaccines. And so just as you would recommend Tdap and that this is normal, or meningococcal, this is normal, this is what we would do for it. We would also normalize HPV vaccination, and not that it's anything different or special or unique. And that it's also infected. Studies have also shown that really emphasizing the same day, as in today when you're in the office, we're going to also give your HPV vaccine in addition to your Tdap and meninge, is important because we know it's hard to get adolescents back into the clinic. And so both of those parts are important. So what has been shown to be very effective as far as communication is saying something very clear and positive, that your preteen needs these 3 vaccines today to protect against meningitis, HPV cancers, and pertussis. And the today being important so that it's something that starts now, so we don't miss our opportunity to vaccinate prior to exposure, and that also the HPV is normalized with our other adolescent vaccines. And this bundled recommendation has been shown over and over in studies to be the most effective way to present HPV vaccination. So you might say, now that Sophia is 11, she's due for 3 vaccines. These will protect her from infections that can cause meningitis, HPV cancers, and pertussis, and we will give those shots today. Some people might want to add a little bit more and explain, a little bit more about each of the diseases. That the first is to prevent meningitis, which is very rare, but potentially deadly. The second is to prevent a very common infection, HPV, that can cause several types of cancers. And parents might not know what cancers are as well, so you might want to share that if they have questions. And the third is the tetanus booster, which also prevents against pertussis. And we will give those shots at the end of the visit. Do you have any questions for me? And that way it's a very normative, fait accompli, if you will, that these vaccines will happen today and that it's part of her normal adolescent checkup. The CDC has put together some real videos from providers, I think, that are very nice. So I'd like to show a few of them here and how they address these issues in their own practice.
When I recommend the HPV vaccine, I bundle it with the other vaccines that are due at that age. So I'll say your child is due for their Tdap, HPV, and meningitis vaccines today. When I normalize those 3 vaccines and make a strong and confident recommendation, I see that most parents are more willing to accept all 3 of those vaccines.
So, and that kind of straightforward should works with most parents. Some parents might need some additional reassurance. And I think what's important, and I do this too, is when someone asks a question or kind of push back, I think we sort of jump to, oh my gosh, okay, this is going to be a long drawn out conversation, and kind of gets all our little antennae up. But actually, they might just have a very simple question or clarification. They might want to know more about what cancers. It may not be as antagonistic as it may initially come off as. So just make sure that you figure out what their real concern is about that. Maybe they have a friend whose daughter or son had a bad reaction, and you can walk them through that. I think just taking that time can actually help quite a bit and diminish any kind of misunderstanding and help you answer their true questions. So one of those might be, why does my child need HPV vaccine? And it may just be a matter of what the parent wanting to find out some more information. And so I think being very clear in the response, HPV vaccination is important because it prevents cancer. So that's why I'm recommending that your child start the HPV vaccine series today. You may elaborate a little bit more on the types of cancer, but it's really the and why today. But I think just being very clear on that is what they're looking for. So reminding them that persistent HPV infection can cause cancer of the cervix, vagina, and vulva in females, and cancer of the penis in males, and cancers of the anorectal area and throat in both. And we can prevent infection with HPV types that cause these cancers by starting the HPV vaccine series today. And really, I think ending on that is important because, again, just keep thinking back to that disease timeline. We want to vaccinate prior to any exposures, the best chance of prevention. So some parents might ask, is my child really at risk for HPV? And they're probably thinking about all the background of HPVs, with sexual debut, and this is not going to happen to my child. But I think just really taking that at face value and responding that HPV is a very common virus that infects both females and males, and that we can protect your child by vaccinating today. And just coming back to that, I like these slides here that show the incidence of diseases covered in the adolescent vaccine series. You have on the y-axis, you have the different vaccines, meningococcal, on the x-axis, the meningococcal, pertussis, oropharyngeal, and cervical cancer. And then on the y-axis is the annual incidence per 100,000. And you can see that pertussis, oropharyngeal, squamous cell cancer, and cervical cancer outstrip meningococcal disease. And everyone's very scared about meningococcal disease, but really as far as the incidence, it's reversed. And in addition, deaths associated with deaths from diseases covered in the adolescent vaccine series, cervical cancer is going to cause by far and away, the most amount of deaths that are associated with these vaccines. And so I think these are very powerful slides that emphasizing how common this infection is throughout a typical adult's life and how it can prevent these types of deaths. Although the other ones are very tetanus, of course, and pertussis and meninge are important, but as far as population health and for the patient, HPV, I think by far and away. And I like this one, this earlier messaging as well, because it really emphasized that it's sons and daughters that need to be vaccinated, not just our daughters. Parents may have questions about why at 11 or 12 years old. A nice analogy is, when do we think the bike helmet should go on? Is it before they get on the bike, or should it be as the car is heading directly at them? And of course, it's before they get on their bike, and that vaccines are the same way. And we want to vaccinate prior to natural exposure. And why 11 and 12 years old? Well, if you look at the Oregon Healthy Teens Survey from 2019, for example, and they asked the question of the teens, have you ever had sexual intercourse? And they asked that at 8th grade, and they ask it at 11th grade. And you can see that in 8th grade, which is about 13 to 14-year-olds, about 10% of the class has reported they've had sexual intercourse at least once. By 11th grade, that's 40% of your 16 and 17-year-olds. And so that's almost half. So basically, once again, like how important it is to start that vaccine series at 11 to 12 prior to them having any exposure. And I think it's nice to have these sort of real life examples of teen reported exposure here. What's been found in studies is that most clinicians wait too long to make strong recommendations for HPV. And the teal bars are when the recommendation is made, and the purple is when it is not made. And if you look on the left axis, you can see there's actually a difference here between pediatricians and family practitioners. No offense to our family practitioners, but just to show, that there are differences between practitioners about delayed recommendation of the vaccine, and maybe even more delayed for males as compared to females. So I think just being cognizant of our practicing biases and how we can improve those is very important. So let's listen to another provider here share their experience.
For me, this is the moment where I actually start asking questions. And so you sort of pause for a moment and you ask the parents to tell me more about that. So I'm hearing you saying that you don't want to give the vaccine. Is there something in particular that is making you think he doesn't need it? Or, why do you think your child doesn't need it? And let them explain sort of more about where they're coming from and what their position is. And then it really helps me to answer their questions or to figure out where I might be able to help redirect them to understand a little bit differently where I'm coming from. The most common one I've heard is, my kid's not sexually active yet, or they're not thinking about sex. And my answer to that is, oh my gosh, that's fantastic. They sort of look at me a little bit strange because they're like, why are you excited about that? And I'm like, well, I'm excited about it because vaccines are something that you want to give before something happens. And so the fact that they haven't started having sex is perfect because it means that we have time to get in both doses of the HPV vaccine before they're ever exposed, which means it's that much more likely that it's going to protect them against cancer. And for most parents, that's enough to sort of flip the switch a little bit and change their mind.
Great. I really I think she gives us just a great answer to that concern. And I think she kind of addressed this. I think in the interest of time, I'm going to move for a little bit through these. But this also comes up that parents are worried that getting the vaccine will be a green light to sex. And the summary is that there have been many studies that have shown that that is in fact not the case. There may even be protective to get the vaccine. And, we don't know why. Is that because in households where the vaccine was given, they had more frank conversations about safer sex, et cetera? Who knows? But it is definitely no evidence that the vaccine changes behavior for earlier initiation of sexual intercourse. So that could be very reassuring to parents. Parents also ask about, people are very interested in the number of doses. How long can we wait to give first 2 doses? And again, we want to start the 2 doses before their 15th birthday. However, it is important to say you've gotten the patient in the office at their 11 to 12-year visit. Let's start now because it can be more difficult to schedule return visits for older teens. So let's start today and protect your teen as soon as possible. In addition, we know that the younger age groups, like the 9 to 10, 11 to 12, they actually have a more robust immune response than the older teens. So that's also another reason to start. Many parents are concerned about the safety of the vaccine, and there's all sorts of horrific things that you can find online. And I think coming back to the data is really the most important thing in responding to that. And I'm going to share this doctor's approach.
When parents raise questions about vaccine safety, I ask them specifically what they've heard, because often they've heard or read one thing that I can address directly, and I explain to them where there are mistaken bits of information and how sometimes people draw conclusions that one thing caused another when they really didn't have anything to do with each other. The other thing is I do like to talk about how vaccines are determined to be safe. And I think it's important for us as physicians and healthcare providers to understand how vaccines are vetted for safety before they're even licensed or approved by the FDA, so that we can literally address those concerns with families and parents from a standpoint of knowledge and understanding the science and the system. Sometimes I even talk about the rotavirus vaccine, which post-marketing revealed that there were issues and that vaccine was withdrawn from the market in less than a year. With the HPV vaccine in particular, we've given over 150 million doses. And truthfully, except for perhaps an allergic reaction, the most serious side effect that's been identified is that some teenagers, Valsalva, hold their breath and faint after they have a vaccine. When you put it into perspective for families and explain the facts, many times you can dispel those safety concerns.
I ask them what their specific concerns are, and I say, wow, that is really frightening. If I were to read something like that, I think I would be a little bit hesitant about the vaccine too. Can we pause just for a minute and let me tell you about what I know about the vaccine. It has been given to millions of people in the United States. It's been licensed in the United States for over a decade, and I am so confident in the safety of the HPV vaccine that I will be giving it to my own son when he turns 11 years old next year.
Sorry about that, but I hope you could still hear the audio. So I think those are some great responses. One question that I've tackled too is, does the HPV vaccine cause future fertility problems? And again, this has been looked at, but that there's no evidence available to suggest that getting the HPV vaccine will affect future fertility. However, women who develop a HPV precancer or cancer could require treatment that could limit their ability to have children. And that's because of the colposcopies, the LEAP procedures, or if they have cancer, total removal of their reproductive organs. So I think it's important to put that into perspective for parents. Some parents, especially in Oregon, may only want vaccines needed for school. I think it's important to explain to parents that school entry requirements don't always reflect the current recommendations to keep your child healthy. School vaccines are focused on respiratory and communicably transmitted in large groups kind of diseases, pertussis, chickenpox, measles, etc. But that the HPV vaccine will provide your child with great protection against a disease that's important for them and preventing cancer. And then, some parents will ask, would you do this? And I think, that if you have, answering honestly that you have or will, plan to, as that one physician did, give the HPV vaccine to your child, might help certain parents kind of say that, yeah, this is important, and even my physician does it, in addition to the AAP and NHS and CDC and all those big names. One other thing about getting to completion of the HPV vaccine series is to make sure that the parent knows when to return, and that when the child is younger than 15, she'll need a second shot in 6 months to a year to have the best immune response, and to make sure that they make an appointment on the way out for that shot. Other things are to make sure your clinic has in place a callback process so that patients getting their first vaccine are called back when they are due for the second. And likewise, if they are already 15, they're going to need their next shot much earlier, in 1 to 2 months. So you might remind them to make an appointment on their way out for 6 weeks after this visit in order to get the next dose. And remember, if a parent declines today, again, as the providers in the videos are saying, find out what their concerns are, start that conversation, see where their worries are, and really that's been shown to be the most effective way to lead to successful vaccination protection for the child.
At that point, the best chance to at least use that opportunity for good is to still use it as an educational experience, to let them know why you feel it's important, to review some of the information that you have and gauge what their reception is. If they're completely against it at that point, I think that it's reasonable to say, I see that we're on two different opinions right here, and we can come back and revisit it. But if in any other case there's some openness to at least hearing you out, I think that that's a good time to at least follow through and provide additional information via website or through other sources you may have in practice.
And those resources can be like what we talked about with the CDC web pages, and we also have some handouts here that'll be available for you all afterwards. One other piece I want to just throw in there is to consider adolescent autonomy, especially if you're dealing with an older teen whose parents have not been wanting to be vaccinated, maybe they're going off to college, and you have those one-on-one conversations with them about their overall health. And so this might be a moment for them to take responsibility for their own health, get their own questions answered, especially if they're sexually active. Bundling these conversations that you have with them around family planning. I mean, you're talking with them about birth control and family planning and how to keep their having safer sex and all these sorts of things. I mean, this is the perfect time to talk about that vaccine and introduce it to them as a choice that they can make for their own future health. And rarely you might get a question if the vaccine is needed for ages 27 to 45. And I think we spoke about this before, but that there are some risk factors like having a new sex partner, for example, that might bring new risk factors into that person's life where it may be beneficial for them to have the vaccine if they have not already had it. And here's one of the websites I was talking about with cdc.gov/HPV, has all sorts of information for your families, for you, and clarifications on dosing, et cetera, that you might have around HPV. And so really suggest going there. Some good handouts as well. There's also more of these videos, which I think can be very powerful, especially when you're working with your office staff. Like, what do you actually say? What should be my response? Sometimes having an idea or having practices beforehand can help when you're in those situations to respond in a caring, compassionate, and also informative way. A little bit more to that point, and I know there's providers on this call, but I'm hoping there's also office staff, because I think it's really, and what's been shown in the studies is really having the whole office around aligned with their communication with the mission to improve the HPV vaccination rate in their clinic, not only HPV, but other vaccines as well. And so that is a positive message that the parent gets when they're scheduling, when they arrive, when they're roomed, that, hey, these are the vaccines we're giving, and you have any questions, we've got some great handouts for them as well. For example, your nurse or MA might be encouraging this convenient same day, same way vaccination by just introducing that. Hey, I see, Pat's going to have 3 vaccines today. They're designed to protect him from the infections that cause meningitis, HPV, and pertussis. And if they have any hesitations, then, the nurse can just reemphasize it's really important to us, and I'm sure the doctor will be able to answer what concerns, and you can share your concerns with them. But really normalizing this and throughout the clinic, it can have a very positive effect on uptake of HPV vaccination. As I mentioned, you staying up to date on best practices. For example, going from the 3 to 2 shot when you're younger than 15, that's been, I think, decreased a lot of the barrier to completing all those 3 shots. So one more reason to start at 11 to 12 years old. As far as, Providence is is really passionate about its CQI projects. And I think that's why I'm excited why your clinic and other clinics in Providence are choosing HPV vaccination to work on. And there's some great data available for you through Providence around HPV metrics. And I'm sure Dr. Rug and the project will be speaking more to that and how to access those, how to look at your own, how to look at your clinics. And doing some drill down work also to find out what might be some barriers in your particular clinic to improving those rates. And so I can't emphasize this enough, and that's one of the reasons why I'm here and I'm available, and look forward to working with you as you go forward on your project and determine what barriers you're going to try to work to minimize and try to improve HPV vaccination rates for your adolescents. So I thank you very much for your time, and I know this is a dense presentation. If we don't have time to address the questions today, I will gladly get back to you by email. You can see my email is there. And remember that you and your clinic, we're all really the key to improving HPV vaccination and cancer prevention. So very excited to talk to you today. Thank you.
Thank you so much, Dr. Buser. So let's see. Please use the question option there on your control panel. I don't see any questions. So please, oh, there we go. Let me see. Okay, so I'm getting a thank you from the audience, and yeah, so please, if anyone has questions, email them to us and we'll make sure that they go to Dr. Buser and she'll be able to answer them via email. Now, before we go, just a quick overview of how to get your CMEC credit. And one thing very important, to help the CDC-funded National AHEC organization, HPV project, please take a moment to complete the survey that you will receive via email in about 1 hour. We'll appreciate it very much. The webinar recording will be available by the end of the week on our website. And if you have any questions, you can always email me and I'll be happy to send you any link or any information you need. Feel free to reach out to me or our office and we'll be happy to be of assistance. And finally, to obtain CME, you must log into www.eeds.com and enter this code 47KEEK. Write it down and please complete the service. You'll get in an hour on your email. And this week on the 19th, we're going to have another webinar about motivational interviewing for HPV vaccination. So if you're interested, send me an email. I'll send you all the information about it. And thank you, Dr. Buser. Thank you, Shar. Thank you to Dr. Rueg. And thank you to all of you for being with us. You have now completed that You Are the Key to HPV Cancer Prevention webinar, and you may disconnect. Have a great day. Goodbye.
Thank you, Carmen. Thank you, Dr. Ru. Thank you.